Okay, it just got really quiet, so I'll start. Hey everyone, I'm Dave. Thank you all for coming tonight. And also, I'd like to give a big thanks to the Academy of Medicine for hosting us. You know, throughout this whole process, they've been super helpful, and they've made it clear that they are truly dedicated to furthering our growth as healthcare professionals. So let's give them a round of applause for just having us. Now, tonight will serve as the first step towards accomplishing CAIPE's mission. That is fostering a culture of collaboration and respect for each other's professions. We figured the best time to start practicing these skills is now. At the foundation of our careers as students, and hopefully our future patients can benefit as a result. And who better to learn from than our wonderful panel of interprofessional experts in the field of inpatient medicine. Tonight, we have Jessica DiPonzio, Beth Palermo, Andrew Rudmann, and Steph Wiemeier. Each member has kindly agreed to discuss their backgrounds and share their experiences with us tonight. So I'd like to thank them for their generosity and interest in our futures. We gave them a list of curated questions to be asked by our moderator, Kevin Lee.
All right, Dave is a little tall, so I'm gonna have to adjust that. So I'm just gonna give you a quick rundown on what we're doing today. We had the curated questions that Dave mentioned, and then we're gonna open up the floor. So if you guys have questions, just hold on to them until we kind of tell you guys when's the right time for that. And then we're gonna have a little small group session. Armand's gonna go into a little bit more, but on the little sheets and handouts you guys got, there's a number on the back, so make sure you don't lose that, because that's how we're gonna organize you guys in a little bit. And that's pretty much it. I hope you guys grab food, and I hope you guys are ready to go. So, first question, yeah. They're just gonna leave me here alone, so I think I can do this. So just the first question for you guys, can you guys please introduce yourselves, kind of give us, I don't know, something interesting or fun that you guys want to talk about, your education background, and then also your current role in this hospital medicine team?
Hi, I'm Beth Palermo. I am a nurse practitioner on hospital medicine service. I also teach at the U of R School of Nursing. I teach in both the undergraduate nursing program as well as the nurse practitioner programs. I am a native of Rochester. I've tried to leave many times and have not been successful, but that's not because I didn't like it here. I think this is a great city and a great community to promote positive change and watch the evolution of healthcare. I'm a graduate. My original bachelor's degree was from Cornell University, where I thought I wanted to work in a lab, which is really funny because I really hated lab once I got doing it. And what I really liked doing was working with people and working with patients. I thought about being a nurse as a teenager, but since my mother had suggested that, I was absolutely not going to do that, as any self-respecting teenage girl would not listen to her mother. So I went on to study biology, but then came back to nursing, and it has been where I have been ever since. I am a graduate of the University of Rochester School of Nursing, both for my bachelor's and master's degrees, and I also am a graduate of St. John Fisher College, where I earned my Doctor of Nursing Practice degree. The Doctor of Nursing Practice is, in the next few years, going to be the entry to practice degree for nurse practitioners. We are evolving to meet the needs of today's healthcare systems and the demands of the healthcare field by sending better educated professionals into the healthcare field. I don't think I have a whole lot interesting to say about me. But I am very thankful to the crew for inviting me, and I'm happy to be here and answer any of your questions.
Hi, I'm Jessica DiPonzio. I'm a licensed social worker for inpatient medicine. I got my undergraduate degree in social work from Keuka College, and then I wanted to get my master's at Roberts Wesleyan. I've been in the field for about 6 years now.
Okay. you had to make up some time because Beth was a little more long-winded. So good evening, everybody. I'm Andrew Rudmann. I'm a hospitalist and a primary care physician, mostly a hospitalist. And I'm a Rochester transplant. I'm originally from Maryland, where I was born and raised. And then I went to college at Duke University, and then back up to Maryland for med school at Johns Hopkins, where I met my wife. And we couples matched to Rochester. She did a pediatric residency, and I, of course, did internal medicine residency. And we were going to be here for 3 years. So here it is now, 25 years later, and we are very happily settled in Rochester. We raised both of our kids. Our oldest son has graduated college already, and our daughter is a junior at Boston College. So very fortuitous for me. I'm a hopeless generalist. I originally wanted to be a primary care physician, and that was my plan. But when my wife was asked to be a chief resident in pediatrics, the first job that was offered to me at the medical center was one that was heavily inpatient. And I said, okay, I think I can do that. I found that I really liked it, and then I didn't want to stop doing it. I kept doing some primary care, but I developed my hospital medicine skills, started developing the program for hospital. I was one of the first hospitalists here, started adding more hospitalists to the group as the years went on, and then we got big enough that we became our own group. We split off from general medicine and became the hospital medicine division, and I became the first division chief of that group and led it for 10 years. And every year we just kept adding more and more and more, and so that I was kind of riding the wave of hospital medicine growth, and actually it continues to grow. Stepped aside from that a few years ago, and I'm working on my MBA degree right now, but I continue to practice hospital medicine, and I'm looking at developing hospital medicine in our region. The whole upstate New York region is a very interesting place, and the medical center is affiliating with a lot of the smaller community hospitals. I think I'm going on a little bit long here, but the university is affiliating, and I'm very interested in the quality of hospital medicine care in our region, so we're coordinating that. And yeah, I think I'll stop there.
Hello, I'm Stephanie Wiemeier, and I am the inpatient internal medicine clinical specialist, I think is my official role. So I typically round with one of the hospital medicine teams, HM4. So a little bit about my background. I'm from Syracuse, and St. John Fisher opened their pharmacy school, and I was lucky enough to be part of their first class, which was an interesting ride. So, and then after that, I did a PGY1 at Upstate in Syracuse, which is, you're a licensed pharmacist. It's kind of like your intern year when you're a med student. So I did a PGY1 there, and then had a crazy ride. Did some ER pharmacy, did some compounding pharmacy, and then ended up at Strong, where I piloted the hospital medicine program and trying to get pharmacists integrated with the team. So it's been an interesting career. So
That's awesome. Thank you guys for sharing. So I have a few more easy questions for you before we get to the tough stuff. So the first one is just going to be, what do you guys enjoy most about your profession or your job? Anyone can start.
I don't know why I always have to go first, so I'll go first this time, and then we're going down the line. Okay. What do I like most about my job? I love hospital medicine. I've always done acute medicine, and I've been a hospitalist NP for a lot of years, I think 16 now. I love that there is something new to learn every day. Things change, the change in healthcare and in medicine is rapid. So there is always something new. The guidelines change, medications change. When I started as a nurse, people who had valve surgery were in the hospital for a week and a half because, they needed their rest and we needed to be careful. And fast forward to today, and you can do them transvenously, or, transapically, and they can go home in a day. The change is just remarkable at the speed of innovation, and we see that in the hospital. We see that it's really a front line for acute care, and I think it's very exciting. I'm a lifelong learner, and as I think everybody else here is, and it's a great place to be if you're a lifelong learner.
What I enjoy most is interdisciplinary collaboration, for sure. There are constant opportunities for growth and learning, and we're part of a team of people with different professional lenses and different perspectives, all working together to develop a really holistic plan for our patients. And like Beth said, I learn something new every single day, and I'm constantly faced with challenges where, I have to think outside the box and come up with creative solutions, and I never feel stagnant in my role. I'm always learning and always evolving, and I love that.
So I went into medicine because I wanted to take care of sick patients, and that is exactly what I do every day that I walk in the hospital. It's the thing that motivates me the most. I love helping patients using my medical knowledge and experience, and working with the team. Obviously, none of us can do it alone. It's very satisfying working with other great people, and I think we have a great team that's strong, and I've been very satisfied with that whole experience, and that's the main thing.
The favorite thing about my job is education. So I enjoy teaching pharmacy residents, pharmacy students, the medicine residents and interns, and maybe even some attendings about medications, and knowing that what knowledge I give to them, they're going to use and hopefully, affect hundreds of patients, if not thousands. So I think that's a really unique, fun part about my job.
Thank you. So I heard interprofessionalism come up. I promise we did not pay them. They volunteered their time here, and we didn't tell them to say anything. So thank you for bringing that up. Our next question is kind of, you guys kind of mentioned your dedication to patients. Can you kind of talk more about your role with patients, maybe how much time you get to spend with them and how much time you would like to spend with them, maybe?
You take it. This one's tough. This one is tough. So the first thing I do when I come into work is look at my patient census list and make a to-do list of everything that I have to do for the day. And then I wait for rounds with the team to prioritize my list. You sort of have to develop your own system of triaging and tackle what you can in the time that you have. And there are days when I feel really good about the amount of time that I spend with patients. It's really fair. I tackle everything on my list. And then there are days like today where you spend 4 hours with one patient and then you don't get to do everything on the list. And things from today I have to move to Monday. And maybe my interactions with patients sometimes have to be more task-oriented than emotionally supportive, and that was really difficult for me to negotiate at first, but I've learned to cut myself some slack and just make the most of the time that I do have with patients. Yeah. You want to go now?
Sure. So I don't spend a lot of time one-on-one with patients. Usually at the University of Rochester, we are strong. Basically, we have some key concepts that we try to counsel patients on. So like anticoagulations, pain meds, and things like that. So one-on-one with the patient, not so much, but I do round with the team daily. So we do it's me and then the whole team. So we usually round with them, and I can help answer pharmacy questions then, or if there's a difficult patient, I'll go back. I wish I could spend all day with the patients and make sure every patient understood every single, medication, but there's only so much time in the day, so I do my best.
Yeah, this is a very important topic. The current complexity of medicine is definitely a threat to our ability to spend time with our patients. And if anybody has ever worked with me, or if you're going to work with me at some point on the hospital medicine service, you will know one particular thing about me. I'm a big fan, or I mandate bedside rounds as a group for my medical team, and we invite the nurses So if we're on a teaching service, we'll invite the nurses and anybody else that is available to come into the room and do rounds with us that way. If I'm not working with residents and I'm working with APPs, and Beth can back me up or refute this, if she's available, I want her to be in the room with me as we're seeing the patient together. I think as was already mentioned, you may have a few minutes to spend with a patient. You may be required to spend a few hours with a patient. You don't really know till you go in there. But I find on a routine basis, one of the problems that we have as a team of professionals is that we're not all on the same page ourselves. So the bedside rounds is at least one point in time every day where somebody gets to review what happened since yesterday, how's the patient feeling right now, what physical findings are present, and let's not try to guess what everybody else is thinking. If there are important physical findings, we need to have a common understanding of that. What data is available, what tests were done, what images were done, let's look at them right there with the patient. What's our assessment and plan? So using our powers of pathophysiology and medical assessment skills, let's just say it right out loud so that everybody on the team, including the patient and the family, hear about it. I think that's one of the best ways. It does take time, but if you do it right, I think you can save time in the end and you can prevent a lot of confusion. So for me, that's the best way to save time and spend good quality face time with the patients. You do run the risk of confusing them, but I would rather err on the side of saying too much than saying too little. And I think you learn a lot about patients and families when you just spend more time with them. And they sort of learn what your routine is too. Some of these patients are in the hospital for weeks and months at a time. They kind of learn, the team comes around it, between 9 and 12, and they really discuss some great stuff. So they try to be there for us.
As a hospitalist NP, the time I spend with patients varies. When I am working with a patient who is assigned to a hospitalist such as Dr. Rudmann, I'm going to spend time with the patient while I round with the attending physician, and that might be the amount of time I spend with the patient. Our team, we are not assigned to a hospitalist. We are unit-based, and so I spend time on a floor. I'm in one place for the whole day. So I will also see patients who are attended on by specialty services and by primary care physicians. And often I spend more time with those patients because they need more time. The primary care doc saw them early in the morning, but I have seen them after they've been seen by 10 specialists or consult services. So they need me to spend time with them to update them on their care. And I like to spend time with patients. We don't get as much time to spend as we like, but you've learned in your coursework that 80% of your diagnosis is going to come from what the patient tells you in your history, rather than all the fancy tests that we have. So using that skill as a good listener is really important, and I try to use that, whether it's to figure out why this man has dysphagia and fasciculations versus learning how to make a better broccoli salad, or learning what it was like to grow up in the 1950s South as a black man. I've learned a lot of things from my patients by spending the time that I can with them.
Awesome. Thank you guys for sharing. So the next question I have is a little bit more of a thinker. So take your time to think about it if you guys need a second. But what would you like some other health professionals that you work with to know about your profession? So maybe stuff that are like common misconceptions, or just things that there's a little bit of lack awareness of.
So I think pharmacy gets a bad rap a lot of the times because we're in the outpatient world, we're kind of that middleman between, insurance, patient, and doctor, and then in inpatient, we have, on top of New York state law and federal laws, right? And then in the inpatient, we have, hospital administration with formulary requests and what medications are cost effective. So often in the hallways you'll hear, well, pharmacy wouldn't let me have that. And actually it's not pharmacy that won't let you have that. We're trying to utilize our formulary appropriately or use cost effective medication. So I think that sometimes is a little bit frustrating here, because if it was me personally, I would give you whatever you want, but we realistically need to keep the doors open so we can treat patients, so we have to use cost-effective medication. But I think over time as we integrate with the team more, because pharmacy integrating with the team is kind of a newer thing. So once we get integrated with the teams better, I think they'll understand that we do our best, and it's not always us that's saying no.
So I think physicians have a habit of failing to acknowledge their appreciation of their interprofessional colleagues, and I think I know I'm guilty of that, and I know many of my colleagues are guilty of that. But what I would want others to know, the pharmacists that I'm working with, the social workers, the nurse practitioners, the nurses, and all of the other, the consultants, the specialists, the surgeons, everybody that we work with who offer something to our patients, I would like them to know that we actually do appreciate their expertise, their experience, and their amazing technical and interpersonal skills. We just don't say it enough, and I think we need to do it more.
Okay, so social workers in the inpatient medical setting are not therapists. There's no brief therapy that can be started and be effective in the time frame that we see patients in the hospital. Yes, we provide emotional support, but not structured counseling, not structured therapy. And in addition to that, and this one happens often, we have to be very realistic about a patient's right to self-determination. So like if they choose not to follow medical recommendations, that's ultimately their choice. Just like if they have a lifestyle or they're living in conditions that make us uncomfortable as professionals, we have to remember that it's their right to live the way that they choose to live. And if someone has capacity to make decisions, then they have capacity to make poor decisions. And as much as we may want to as social workers, we can't fix those long-term chronic problems in the inpatient setting. Yes, the hospital is designed to be a short-term place to stabilize the acute need, medical need, psychosocial need, and then give patients the tools and the resources to follow through and follow up once they leave the hospital. That's the biggest thing for me.
I would want people to know, or I want people to know, that nurse practitioners are valuable, well-educated professionals who are independent and have multiple ways to contribute to patient care. Our nursing backgrounds help us view patients and families in very holistic ways, very big picture thinkers. And we have the ability to work through complex systems because that's what we do all the time. And our advanced practice training has prepared us for the diagnosing and treating similar along the lines to what you're learning or about to embark on. And I hope collaborating in that same manner. I think a misconception about nurse practitioners, it's better now than when I started, but we are not physician extenders. We are actually independent professionals who can practice in a very independent but collaborative manner. We're not an extension of somebody else's profession.
Thanks. So we're just going to continue with the interprofessional theme since that's what we're all about. But can you guys tell us a little bit about the biggest roadblocks to interprofessional collaboration that you guys have faced? Specifically, I can give some examples such as structural ones, financial, legal, educational, stuff along those lines.
All right. I have a couple that I can think of. I think one is personalities. There are some people who are just super collaborative, embrace collaboration, embrace the skills and individual characteristics that we bring to a healthcare situation, and some don't. I think along the lines of personalities, there are some people who are fearful of their turf. And I did one time have a physician say, well, nurse practitioners think they're gonna take over everything. And I'm like, God forbid. Because you don't want me taking over anything. That's not what, that's not what the purpose of the role was when it was developed. So I think, but the people who are on this panel, I find them very collaborative. we are, a lot of times when Dr. Rudmann was talking about the rounds, that's a divide and conquer. Listen, I really ticked off this family member yesterday. So, okay, well, I'll go in and talk to them today. You take care of this. So, we can work together, but not every personality is up for that. And I think the other thing is, speaking with my educator hat on, is, and I was telling your esteemed moderator, is that education is difficult. It's difficult to coordinate interprofessional education. Medical students are full-time, nurse practitioner students are part-time, so it's hard to coordinate schedules. I mean, look at, you're doing interprofessional collaboration on a Friday evening. Sorry to point that out to you, but, because your schedules are packed, your curriculum is packed, nurse practitioner curriculum is packed. People like Dr. Rudmann is an educator, and myself, we have a lot of people and organizations telling us what we have to do and how we have to have you prepared when you leave our school and become providers yourselves. It's hard to do, and I think that's one of the biggest barriers, is just being able to coordinate those efforts.
So I have sort of a unique perspective. I don't have one home base, one home unit at the hospital. I follow patients on multiple units throughout medicine. So I have the opportunity to see how different teams operate. And what sets apart the really strong teams, the teams that work really well together, is communication. Hands down, communication is essential for effective interprofessional collaboration. It really makes a huge difference when we have the opportunity to round as a team, where providers communicate the plan, they have input from nursing, care coordination, social work, the therapy team, and we're all working together and on the same page, working towards the same patient outcome. I've seen how lack of communication or poor communication really just leads to dysfunction and frustration all around. And you can't rely solely on what's documented in the medical chart, because medical documentation is designed to be concise and the most relevant information, and things are dropped. So it really is very helpful when things are also communicated verbally.
So I have a long list, but I'm not going to expound on everything or too much. But things that interfere with interprofessional collaboration, one thing is different work schedules. So Beth may be, as good as our APPs are or our physicians, we don't work on the same schedule often. So she may be on a stretch of maybe 1 day or 3 days or 5 days, but it might be different than what I'm doing. So we may be sharing a patient one day, but we're not sharing that patient the next day. She's off, somebody else is on, or I'm off, and then one of my colleagues is on. So I think that lack of coordination of work schedules is one issue. Lack of geographic control over patient flow. Ideally, you work with the same people in the same spot with the same patients, but our patients, as you know, Strong is over 100% capacity frequently, so patients wait in the emergency room, they get assigned inpatient care teams, we start taking care of them, and then, the first open bed for this patient is on a unit that's, not the one where most of your patients are. Okay, well, so either you hand the patient off to somebody else or you follow the patient to that unit. Well, then now you could easily see how the deck could get shuffled every day. So that's a barrier. The EMR is a huge barrier. We all have to, they say if you didn't document it, you didn't do it. So not only do you have to do it, but you got to document it. It takes time to figure out our EMR. With my work in the Southern Tier, I can tell you that Epic is light years better than anything else in the region that I have seen, and I'm more of a fan now that I've seen other computer systems, but it is tough. I mean, it takes up a lot of time, so that's a big barrier.
I think the biggest roadblock for pharmacy being involved in interprofessional collaboration is during the week, one pharmacist covers orders for like 200 patients. On the evenings and weekends, there are like 400 to 600 patients. So we just don't have the resources and pharmacists enough for each unit or each team. So And a lot of that has to do with our services aren't billable, so we don't make revenue for the hospital. So I think that's where pharmacy lacks ability to be able to participate.
All right. Thank you guys for sharing that. So next up, I have a question that might be a little difficult for you, Dr. Rudmann. This question is just about, can you tell us something that you appreciate about another profession at this panel? We're going to try to limit it to one person, because I know Dr. Rudmann is going to want to say something about everything. But maybe we'll have him last, so if there's time, he can speak to everybody at the panel.
This is easy. I could say something spectacular about any one of them, definitely. But I'm going to say I'll mix it up. For my appreciation for the pharmacist, I think some of the best talks that I've heard about medications and how they're used and what the mechanism of action is and the benefits and the risks of the patients have come from pharmacy students and pharmacists who are on rounds who really embraced the challenge that we said, hey, we'd like to know more about metformin, and boy, did they hit the ball out of the park. So I am just incredibly appreciative of the skills that the pharmacists bring to the inpatient team. Was that good?
Does anyone else want to answer that question?
Sure. So I appreciate our nurse practitioners, and specifically the approach of nurse practitioners. They're not symptom only focused or diagnose and treat only focused. I've noticed, and correct me if I'm wrong, that they have a more comprehensive, more holistic approach. They take the acute medical issue and they look at how that issue is impacted by, or how it impacts the whole person, the home life, the environment that they live in, their culture, and what that means for treatment and the plan in general. And while the diagnose and treat approach is necessary and certainly valuable, I feel that patients get more comprehensive care when they have a nurse practitioner on the team.
I appreciate my physician colleagues. I appreciate their knowledge. I appreciate their focus on evidence-based practice and best practice. I have found my physician colleagues to be incredible connoisseurs of the literature. And if there is something new, or, and not that I'm not an evidence-based practitioner, but their extensive knowledge and how much work they put into staying up to date on things, I truly appreciate, and I learn a ton from them. And I also appreciate my social work colleague. I wrote her down too. Many problems that we have, many of these patients have complex medical and social needs. The patient with addiction who needs, IV antibiotics for their endocarditis, but also needs rehabilitation and stabilization, or, the patient who's wants to go home, the older adult lady who wants to go home, but her daughter, there's evidence of financial abuse. So many times I need my social work colleagues, such as Jessica, to help work through those issues, because we know that medical issues often don't get better when social issues are severe.
Even though I don't get to interact a lot with social work, I really do appreciate social work a lot, because they get my patients the medications that they need. So if they have insurance issues, or if they can't find their medication, they have funds that they can draw from to make sure that the patients go home with their medications in hand, so that way they hopefully don't come back to the hospital. So I think that's really helpful.
I actually really appreciate social work too. No, but that's the truth. I know that was a tough question, because I made you guys pick favorites, and I'm sure there's a lot you appreciate about a ton of other professions. So That was about it for the curated questions. I mean, I can keep asking more and more questions, but we are going to open up the questions to the audience. I don't know how this works. Anyone have any questions?
How's it going? I'm Armand. Does anybody have a question? Perfect.
First of all, thank you so much. That was informative. And I was wondering if you could talk a little bit about lessons you've learned in resolving conflict or differences in opinion in a team approach. It's very broad. My apologies.
Go ahead.
So are you referring to conflict between clinicians or between clinicians and patients? Between clinicians. Oh, okay. All right, so there are different types of conflicts that occur between clinicians. So one type of conflict could be if I'm taking care of a patient. I mean, one of the nice things about inpatients is they're always assigned to one attending of record. So if it's assigned to me, I'm in charge. If I pass the patient off to a colleague, they're in charge now. And then if I pick them back up on Monday, I'm in charge again. So if we have conflict about what happened over the weekend, it's on me to discuss it and work it out with my colleague, because we don't want the patients to suffer. We don't want them to get, the yo-yo effect or, back and forth. So I think just the assignment of a patient to at a particular attending physician takes care of some of that. Now, between generalists like myself or primary attending of record and a consultant is another story. That's what happens more often, and that's a tough one to deal with because we do rely on our consultants to give us their expert opinions and often to do procedures that we can't do. And when we have a disagreement with them or conflict, it usually results out of our concern for our patient. And so the healthiest way to approach that is to just say, I'm concerned about my patient. I think they have this, that, or the other. I think they really need this. And often they'll have just a different understanding of the patient's medical condition, and so it's a good learning opportunity. Often I have, called up my colleague and said, I really think this needs to be done, and this is my understanding of what's going on. And they say, well, let me tell you what my understanding is, and let me tell you what I think needs to be done. And often it's something that can be resolved with that kind of a discussion. If it is not resolvable like that, we have to kick it up to our superiors. So every physician in the hospital has a division chief. Every division chief has a department chair. Every department chair has a chief medical officer. You can sort of ratchet it right up the chain of command if you have to. That most often doesn't happen. I don't know what you think.
No, I don't have any.
I'd be lying if I said we didn't have conflict. Sometimes it's over, just as an example, this patient's ready to be discharged, and there's a ton of pressure on us as hospitalists to move people out. And sometimes you think, I don't think they're ready, and you can't leave your gut feeling. You need to talk about that and say, I don't think they're ready, and have a sound reason. And I think because we are professionals, we know that you have to have a sound reason why I think he's ready to go, and I have to have a sound reason why I think he needs to stay. And usually we have to discuss it. And I think there is an element of personality that drives that, but I can say on our hospital team, we just talk it out.
All right, thank you very much. Next question.
We need the mic, actually.
So you guys talked a little bit about the hurdles that you face with interdisciplinary care. Can you discuss a little bit more about the systems-based hurdles that you might face, whether it's with insurance or health policy and things like that?
Well, where insurance is concerned, we are all on the same team. So we don't have a lot of interprofessional conflict in that respect. But I think some of what Dr. Rudmann alluded to is some of the challenges in the system come from things like the electronic record. You know, a note doesn't suffice. It's not the same as somebody talking to you. Likewise, somebody talking to you doesn't get on the record for the next guy to take care of. The system of, you know, I'm sure the hospital would love me to work 100 hours a week, and I can't, I can't do it. So naturally, I'm going to transfer care to somebody else. The constant transitions of care from ICU to floor, day to night, from provider to provider. I think that's a system problem that I think is a huge barrier to our interdisciplinary care, because it's definitely somebody, you know, the person who called the patient to the attending heard one story, but when I saw the patient, I heard an entirely different story, and I think that kind of sets us up for, well, how come he doesn't, you know, without knowing that piece, it sets me up to think, well, what is he even talking about? So, you know, you have to sometimes suspend judgment and not jump to conclusions, because the system kind of puts us in that untenable position.
Do you have anything? No. I don't really have a whole lot to say about this necessarily. Insurance and what they will approve versus what they won't approve is an endless frustration for me, because it doesn't always matter what benefits the patient the most or what the patient needs. It's limited by what insurance is willing to pay for, and I have to go in and disappoint patients all the time when things aren't covered, or when home care is only 2 days a week and they could really benefit from 5. I don't know what to do about it, you know, I don't know, it's frustrating.
I just thought of something I could mention that hasn't come up already, and that is so the system compensates hospitals based on the level of care of the patient, and then a lot of modifiers like the specific diagnoses that you're taking care of. But one big hurdle is getting the level of care right, and I'm talking about observation level of care versus inpatient level of care. And that's not a topic that interests most physicians. Unfortunately, it's reality, and physicians and APPs and nurses, utilization management nurses, are the clinicians closest to the patient. We're in the optimal position to understand this and get it right from the beginning, so it's not unclear, or changes don't have to be made down the line, because there's all kinds of rules and regulations about if you don't do it right, you can't bill anything for the whole stay. Right, patient comes and goes as an inpatient, but they really only qualified for observation. Some insurances say, well, too bad, you missed it. You missed the opportunity to get it right. So I think that is a reality. Insurances have to have rules, and they're not going to pay $10,000 for an observation stay. They're going to pay $1,500 or $2,000 for the observation stay. That's a big difference. And if you're the medical director of the insurance company, you're going to be managing that sort of thing aggressively. And my opinion about this is that we just have to do our best to understand it and work with the system. And if you were to take, I've heard people say, well, gee, we really need a single payer system and then all that'll go away. I don't think so. I think utilization management is going to be aggressive even under a single payer system. And currently we're already, Medicare is like 50% of coverage of all of our patients already. So between Medicare and Medicaid, you've got now 70%. We're already largely there to a single payer system, and they have lots of rules that apply about level of care and other insurance types of things. So that's a hurdle that we need to overcome. I think we could do better with it.
Thank you. Anybody have another question?
Hello.
What do you mean specifically? Like,
So if you order a certain test, or as a part of you feel as a team that that's the best approach, but then you have to go through a peer review system with insurance.
oh, you mean like a prior authorization? Oh, Stephanie could talk a long time about prior authorization. No?
I don't do that.
Oh, you don't do the prior
No,
authorization,
this-
okay.
And we dispense everything from pharmacy. You order it.
Okay.
We don't worry about insurance until the end.
So often, if we want to send a patient out on a medication that's not covered or that's restricted, has to be authorized by a medical director at an insurance company, we have to go through a bunch of hurdles and wait for the response. And sometimes it's on their time frame and not on ours. It's very frustrating. It's one of my least favorite things to do. But it's not as prevalent. I agree with Stephanie. It's not as prevalent in the hospital as it is in the outpatient setting. So the outpatient, it's just a different environment, and there's probably most good effective practices will have a process of dealing with that, so it doesn't fall all on one practitioner. Discharge. So yeah, you do a lot of discharges. So what do you come up to issues like that? Like you want to order a CAT scan for follow-up for your patient, and no, you don't even do that. You just recommend that the primary care physician do it.
All right. I think we have a question over here.
This might be getting into the weeds, but what are 2 or 3 things on your wish list that you would like to see implemented in order to maybe improve more or promote more interdisciplinary work?
You had a sharp inhale. I thought you had something.
Because you know what, the first thing that came to my mind was time. There's just never enough time. There's this constant time pressure. I remember at one point the hospital wanted us to have all of our discharges out by 10 o'clock in the morning. It's just not, are you kidding me? If I started at 3 a.m., I could do that. But time where if we weren't all so rushed and so pressured by the volume of patients we have, by the volume and the complexity of them, I think we could have, if we could, like our unit rounds, our goal is a 30-minute check-in. And, if we had an hour or 2 hours to discuss people, we could get a lot done, but then that would be 2 hours of the day that we weren't discharging, admitting, reviewing tests, et cetera. And so I think we could really promote collaboration better if we had more time. And I think that's one of the nice things about your interest group having a meeting. This is a very nice, relaxed setting, and we should probably do more of that.
So are there any industrial engineers in the audience? No? So there is this field of industrial engineering. These people study processes, and they wring out all the redundancies and the unnecessary steps. Some of that is being applied to medical care, and we're not there yet, but I think working with experts in process has a role. I mean, we've all met with Six Sigma and quality improvement people, and it's still kind of in its infancy in terms of actually changing the system, because the system, no matter where you work, is so complex. But I think taking a systems perspective has some potential. And then I think probably easier than that would just be developing better EMRs that just work better for us, so that we can find information that we need more quickly. And that's my number 1 vote, but 2 would be just industrial engineering as applied to medicine.
My number 1 vote would be more pharmacists. So we had pharmacists on every team, pharmacists on every unit, so then that way we could help our patients, better.
Awesome. So I think that's about the time we have for audience questions.